Dr. Supriya Samak. Her topic is safety and clinical outcomes. You are Supriya, right?
Yes, ma'am.
Yeah.
Good morning, everyone. My name is Dr. Supriya Samak Shri Ganesh. Thank you to the esteemed panel for this opportunity. Today, I'll be talking about safety and clinical outcomes of a new anterior capsule fixated toric IOL with swivel haptics. So, the most common pitfalls of present day IOLs is, first of all, the effective lens position. Then we always look at the rotational stability of toric lenses, and the fact that premium or toric lenses cannot be used after complications like PC rent, zonular dehiscence, etc., aphakia, etc. No premium IOLs are present for aphakia, and many rings and steps in multifocal lenses cause photic phenomenon. So there are a few existing solutions for capsulotomy fixated IOL designs, the first of which is the bag in the lens IOL or the morture IOL. For this, a perfect 4.8 mm rhexis, preferably a femtorhexis, is required, and a posterior capsulotomy is required. So the anterior and posterior capsulotomy are captured in the IOL. So it's called the bag in the lens IOL. This has a groove in the periphery. The other lens is the masket IOL design. This also has a peripheral groove and requires a femtocapsulotomy of 4.8 mm, and failure to capture the capsulotomy can cause a capsular block. There's also the Femtis IOL, which has two haptics. The inner haptics clip on to the capsule, and this also requires a femtocapsulotomy of 4.8 mm, and this can cause the haptics can clip onto the iris, which can cause iris tissue damage. So each of these lenses, which are the current solutions, require a femtocapsulotomy and have other drawbacks. So the new design of the swivel haptic IOL is as follows. The lens looks like this. It's a single piece open loop hydrophobic acrylic IOL, which has a 6 mm aspheric optic with 13 mm overall diameter and two extra haptics, two swivel haptics of 2.5 millimeters each, made up of a proprietary material, which swivel over a pivot. This lens has an A constant of 117.1 due to the anterior effective lens position, and it has a 360-degree square edge. So 8 eyes of 6 patients fulfilling inclusion and exclusion criteria were included in the study. The inclusion criteria was patients with cortical cataract or nuclear sclerosis with corneal astigmatism of more than 1.5 diopters, because it's a toric lens, informed consent and willingness to participate in follow-up visits. Exclusion criteria were mature intumescent cataract, subluxated lenses, pseudoexfoliation, any other pathology. This is a short video of the surgical procedure. You can see the swivel haptics lens. Before loading the lens, we always check that the swivel is moving. There is a hole at the end of the swivel haptics. So this is normally loaded in a backloading cartridge with the swivel haptics closed. This is a regular backloading cartridge in which it's loaded, and it's implanted in the lens. Once it's implanted in the anterior chamber, it's put into the bag, and the swivel haptics are opened up above the capsulotomy to capture the capsulotomy to the swivel haptics. Here the advantage is that you don't need a perfect 4.8 mm rhexis. You can even do a manual capsulorhexis, and the visco is easily removed from even under the lens. You can see that it is aligned and centered quite well. So our results, the pre-op astigmatism average, the mean pre-op astigmatism was about minus 1.92, and post-operatively we found that the mean was 0.21 plus or minus 0.33, and the spherical equivalent is 0.27 plus or minus 0.42, which shows good visual outcomes. The mean post-op IOP on day 1 was 15 across, and 1 month post-operatively, none of these eyes showed any signs of pigment dispersion on gonioscopy. The mean post-operative ACD at 1 month was 4.067. UBM and slit lamp photography were done in all cases and showed a stable IOL with swivel haptics in position. All cases showed the toric IOL in the intended axis at post-op 1 month with no IOL rotation for toric lenses. No patients reported any symptoms of dysphotopsia, and there were no intraoperative complications in any of the 8 cases. So the potential advantages of this lens is the rotational stability, A manual or a femtocapsulotomy can be done. Better centration, less tilt. No special instruments or training is required. No special equipment is required. Here you see a UBM with a relatively anterior and fixed effective lens position. So we can actually determine the effective lens position for better visual outcomes, less negative dysphotopsia. And even in complex cases such as PC rent with intact rexus, this can be used. The holes in the haptic allow for scleral fixation with proline, and even with zonular dialysis and aphakia, this lens can be used for scleral fixation.
Your time is done, huh, actually. Yeah.
All right. Thank you.
Thank you. So you have any question? I do have. Yeah.
What is the particular indication for use of this lens out of the standard available lenses?
So this lens can be used in routine cases. In any cases it can be used. The speciality of this lens is, first of all, for toric lenses, one of the main drawbacks is the rotational stability of toric lenses. So this lens, since it fixates to the anterior capsule, there's no chance for rotation of the lens in the bag. And the other indications would be if we're using toric IOLs.
My question is simple. Will you use this lens routinely for any toric implantation?
Yes, sir.
Forgetting other lenses available
Yes,
at
sir.
the moment?
Yes, sir. That is the idea, that we can use this routinely not only for toric lenses but for all lenses, because we can determine the effective lens position. That is the main part of the biometry that till now we have not been able to actually determine, which causes that.
That means apart from rotational stability, you says that as it fixated on the taking support on the anterior capsule.
Yes, sir.
So effective lens position is always fixed.
Yes, sir.
So your A constant is always giving
7.1. Yes, sir.
That is the reason you want to replace all other standard lenses with this.
Yes, sir.
That's great.
Yes.
2 points. What are the negative points of this lens?
The negative.
You gave the advantages. You didn't say
Yes, ma'am.
disadvantages.
One of the drawbacks of the study is that we have only implanted it in a very few eyes.
8 eyes. Right?
Yes, ma'am, 8 eyes. So previously, a study was done with a non-toric version of this lens, for which we did a study with 30 eyes, which gave good results.
How
But
long is the follow-up? The longest
for
follow-up?
the first study was a 6-month follow-up.
Only.
Yes, ma'am. Post which the paper was published. But now we have longer follow-up of up to 2 years.